right, good afternoon, everyone, and welcome to our Fall Social Determinants Forum on Health and Housing. During this forum, you'll hear from leaders from 4 organizations about the intersection between health and housing and their work to address individual and community housing needs. My name is Melissa Quick, and I am a co-chair of Aligning for Health, which is an advocacy organization focused on addressing the barriers and challenges that limit our ability to improve health outcomes and well-being for all. But before we start, I wanted to take a quick minute to provide a little bit of background on social determinants and the purpose of this convening. At Aligning for Health, we believe that social determinants factor into our overall health and well-being, and that healthcare itself is only one piece of the equation. Lack of adequate housing and nutrition, socioeconomic status, and race all contribute to our health. As a coalition, we are focused on developing and promoting actionable policies to address such challenges and to create opportunities for states and local governments, healthcare organizations, and non-healthcare organizations to work together to develop cross-sector coordinated solutions to address health and housing needs. To further this work, we are excited to convene today's forum, which is intended to bring together experts from across the health and housing continuums to learn from each other and to discuss current opportunities and challenges in addressing housing needs and improving overall well-being. We chose to focus on the intersection between health and housing for our first forum, given the strong interest in housing programs and services among many in the healthcare sector, the emerging partnerships between the health and housing organizations, and the growing evidence that suggests that helping to provide stable, affordable, healthy housing can improve health outcomes. Moving forward, Aligning for Health plans to convene quarterly forums, which will each be focused on a particular social determinant, whether social isolation, food access, or transportation. But for today's forum, we'll first turn to our incredible panelists who are each working above and beyond to create partnerships to advance innovative and effective practices and to improve health equity. They will detail research on the impact of housing on our health, describe the structural correlation between race and homelessness, and highlight their work to address housing needs across the continuum. First, we'll hear from Marcella Maguire, who is the Director for Health Systems Integration at the Corporation for Supportive Housing, followed by Bobby Watts, the CEO for National Healthcare for the Homeless Council, then Kevin Progar, who is the Senior Project Manager for the UPMC Center for Social Impact, and finally from Callahan, Seltzer, the Acting Director of Housing for LISC. Their presentations will also highlight some of the opportunities and challenges inherent in this work and will establish a foundation for us to better understand the scope of these issues as we move into this discussion portion of this forum. After the presentations, we'll move everyone into pre-assigned breakout rooms where you'll have the opportunity to actively discuss some of these issues and focus on a few key discussion questions. Then we'll come back together for a larger group discussion. The panelists will help to tease out some of the key themes from the breakout rooms and will provide their perspectives on the future of health and housing policy. As a reminder, throughout the forum, although the breakouts and the group discussions are intended to be interactive, please remember to keep your microphone muted until the breakout session so that we can all hear the panelists. And please disable your camera as well if possible. We will be recording the presentations, but not the breakout discussions, and we'll post the recording to our website. Finally, as a reminder, if you have any discussions for the panelists, additional resources or information that you think would be helpful for others participating in the forum or other comments, please enter them into the chat box. We want to encourage a robust discussion and will aim to get to as many questions as we can during the group discussion. And with that, we'll turn to our first presenter, Marcella Maguire. Marcella is the Director of Health Systems Integration for the Corporation for Supportive Housing. Her work nationally focuses on the intersection of the housing and healthcare sectors in the financing, policy, and implementation arenas. Prior to joining CSH, Marcella worked for 17 years for the City of Philadelphia, leading efforts to integrate behavioral health, managed care, and affordable and supportive housing systems to strategically address community needs. Marcella?
All right, thanks. Melissa, can you hear me?
Yes.
All right, great. Well, welcome everyone. Next slide, please. In the first slot, we highlighting, I'm still seeing me. And there we go, okay. So wanted to use this time to highlight some of the current themes that we're seeing in the work throughout the country. Next slide, please. And for those of you who aren't familiar with CSH, we're a national nonprofit, 29 offices in 13 states, a touchstone for new ideas and best practices through training and education, through lending, we're a community development financial institution, through policy forum and consulting and technical assistance. Our goal is to increase supportive housing capacity and supportive housing quality for vulnerable populations nationwide. Next slide, please. I put in this slide to start with our conversation today because I really just wanted everybody to be able to take a moment, take a breath. Amid all the chaos around us in the work we're doing in health and housing, you have to look for the balance. You have to look for the focus and designing priorities that match our values and our goals. Those priorities all have to be considered from a values perspective, what's right and what's not right, from a policy perspective, what's the environment we're working in and what are the opportunities. From a budget and fiscal perspective, we know we're in tough budget times and are likely to be for the foreseeable future. From the current crisis perspective, from COVID, which has been around for about 6 months, from the national moment of racial reckoning we're in, while the issues have been around for hundreds of years, they've come to a forefront in the last 4 or 5 months, and that gives us opportunities. We have to think about those priorities and balance from a network perspective. Know what you know, make friends with people who know what you don't know. And also from a capacity perspective, we want to be able to execute all that we're able to do. Think about this also and the balance that we're trying to bring in health and housing from an information perspective as well. What do we know quickly? What valuable information is and isn't able to be pulled together quickly so we can make our best guess? There's research for many of our questions. There's also not research, and we have to work in the promising practices space. Oh, and let's not forget to think about politics and all of this as well. Next slide. So we're going to talk about a couple of themes. One, the conversation has changed. There's an opportunity here in health and housing. The conversation about equity has exploded in ways that we could only have imagined 4 or 5 months ago, et cetera. Let's seize the opportunity. Let's collect our data. Let's analyze information the way we need to. Let's push out that information, and let's make the change that we all wish to see. We see the health and housing field moving beyond the message of social determinants of health is important. That, I think, is a common, everyone agrees on that. We don't need to sort of to share that as much as we used to. We need to say, okay, but what are we going to do about it? The most innovative work we're seeing in the field is individuals and companies, health plans and health centers, all healthcare sector partners that are tracking social determinants of health needs via a closed loop referral network. And the goal of that is not just to be able to make those referrals, which is obviously important in trying to address those needs, but also to build to actionable data, thinking about gaps analysis, thinking about the need to ensure that not only for some places our referrals will work, and that's wonderful and we have great information, but for a lot of places, particularly in the housing space, there just is not the capacity. Let's build that actionable data to say how much do we need. We can change the conversation and go from abundance to scarcity models. A scarcity model says we have too few resources. Let's strategically think about exactly what it is we need and use those resources to do the best we can, knowing that we fall far short, certainly far short of our equity goals. An abundance model thinks about, okay, what do we need to do the work? How many units do we need of supportive housing, which is the way I think about things. You may think about this as, what's my provider network needs from a health plan perspective? What's my state health policy goals if you're working from a state? From a hospital, how do we ensure essential services and benefits and workforce here? So thinking about this more from an abundance model, and then creating those gaps analysis and developing budget models for what's needed to fill those gaps. I always say in my former role with the city, I knew I needed more supportive housing. I didn't know exactly how much more I needed, and I certainly didn't know what it cost. Those are some of the details that we're trying to build out now. Some details, important information that we're trying to build out. You can't make the ask until you know exactly what you're asking for. We're seeing new performance metrics being developed around these referral networks that are happening. We're seeing new public-private partnerships to try to say, what's the impact here? Where does that information around social determinants of health, just knowing, making sure my hospital knows where the food pantries are, making sure my hospital knows where the shelter beds are, and then where did people people get there and how, what were the challenges when they weren't able to get there? Is it the person needed more support? Is it the, as I like to say from the food pantry metaphor, is it that the cupboard was bare? You now know where to send people for the food pantry, but the cupboard is bare. And then finally, building sustainable models. Once we know how many more units we need, how much more access we need, what are the building the sustainable financing models in order to make those continue? The fragmentation of issues and the lack of national leadership, I would say, on many of these is driving a new wave of state and summary activities. I've got one good example here. Bloomberg Philanthropies has done a wonderful policy tracker of local initiatives. So plans across the country are diving into this work, and you're going to see in the next couple of months some great system leaders talking about exactly what they've done, what they've been able to accomplish. Certainly they're going to have the ROI analysis, and I believe they're beginning to build on the equity analysis as well. And then as we think about what's coming next, we think about the next wave. We think about a measurable investment and tracking impact. It's not just enough to know that an investment was made. It's not just enough to know that we built, say, a closed loop referral network. It's important to say what was the impact was, where did it make change, where did it not? Where did it build the community, the thriving communities we wish to see? And then we also want to see an investment consciously and intentionally focused on equity. We've done so much work over the last decade or two to translate the inequities and help understand the inequities in our communities, particularly around health. I'm going to talk about housing, but around health as well. Now, when we make the investments, does it make a change on the equity in our communities or lack thereof? Next slide, please. COVID's driving us to a broader, really moving beyond cross systems to what I might call an ecosystem approach. Oh, back please. It's driving us to an ecosystem approach. It's driving us to collaborate in the public health space. Really, that had been not so much, but now it's essential with public health to stem the virus spread, to address needs where quarantine is not possible or limited. A lot of the work CSH has been doing over the last 6 months has been helping communities stand up hotels and other places where people who are experiencing homelessness or housing instability, excuse me, are quarantining and trying to address needs where that quarantining is not possible, yet it's important for the health and safety, not only of ourselves, not only of these individuals, but really for our whole communities. Back to that slide. Okay, thank you. And obviously we need to collaborate with public health in order to think about and should be planning for distributing vaccines when and where that becomes possible. If there's one takeaway I want to highlight here, it's the partnership possibilities with new housing related resources. Via the CARES Act, the Federal Emergency Solutions Grant has shifted one time only from a $250 million annual grant to $4 billion that must be spent by the end of this year. That's a huge system change. That means that housing has resources. How do you align? How do you partner? How do you ensure your members, if you're a health plan? How do you refer if you're a hospital? How do you think about that in the time going forward? We also have a link to the new mainstream voucher awards that came out in the past couple of weeks as well. These are HUD-funded subsidies for non-elderly disabled persons. They're awarded to a variety of housing authorities and state housing finance agencies or state housing authorities. The links to all of those awards are on this as well. So housing has often been, shall we say, quite honestly, the poor relation at the table, at least for a short period of time. There are resources there. How do we use these new resources to strategically build the partnerships that we know we need? And the ecosystem approach also includes silos, addressing the silos within silos within silos within the healthcare sector, and then also really building an authentic community-based, authentic partnership with community-based organizations that need capacities of building support. We've seen those closed loop referral networks ask community-based organizations to start putting their information in. We haven't seen why. We haven't seen them explain why that's important and what that information leads to. And unfortunately, giving better information about what community-based organizations do is that only sends more people to their doors. I will tell you that agencies that I work with locally and nationally, the one problem they don't have is not enough customers. They need more resources. They don't need more customers until they can get more resources, and then they're happy to oblige. Next slide, please. Talk so much about equity. I just want to share a couple of really important graphs and data and resources for trying to track racial inequity in your communities. This is from the National Alliance on Homelessness. They've done wonderful work addressing racial disparities. Bobby's going to talk a little in his piece about how we got here, but let me just use these data to tell you where we are. Where we are as African Americans are vastly overrepresented. You can cut the data nationally, you can cut the data by states, you can cut the data by localities, and you always see a significant overrepresentation of both African Americans and Native Americans as well. That means that specific community strategies to address the needs of these populations, to engage these populations, need to be put in place to address these disparities. And another scary thing to say around housing, next slide please. There's a lot of conversation happening about the homeless definition at times and who gets and who realizes. I don't feel like that's a really valuable conversation. I think what's important to make sure an audience like this knows is that pre-COVID, 1 in 4 Americans who qualified for housing assistance could access it. Housing assistance is not an entitlement program like healthcare, like Medicaid. It's the budget goes as far as the budget goes. And even during COVID and after, and well, we're mid-COVID, I should say, perhaps, the housing uncertainty is even greater. This is a chart from CityLab using Census Bureau data to look at in July who missed July rent or mortgage and have little to no confidence that they can pay in August. So housing assistance, the coming eviction crisis, I really want to highlight the great work from the National Low Income Housing Coalition, the great look from Matthew Desmond's Eviction Lab at Princeton, et cetera, highlighting how challenging housing is going to be, not just for people currently experiencing homelessness in the populations that we've all worked with historically, but the new populations who are impacted by what's happened to our economy and how housing continues to be out of reach for so many. Next slide. I am, just because I'm close to out of time, I'm going to go a little bit further. Just say long-term success happens when these details are here. I also want to highlight the link out today, HUD's new data sharing toolkit, and that brings together how you do large-scale data sharing between systems, between health and housing in particular. Really, really excellent. Next slide. And highlight a couple of strategic examples we've seen where healthcare has really gotten into the housing business in Massachusetts, setting up their isolation and recovery sites. In California, Project Roomkey, which assisted early COVID and currently individuals who particularly were 65 and older, had chronic health-related conditions. When we were told to all quarantine in place, these were the resources for people who that was not an option for. And then Project Homekey is California's significant investment in affordable and supportive housing options in order to ensure that those individuals, particularly the most vulnerable among them, leave to supportive and affordable housing, not back into homelessness. Chicago completely redid their coordinated entry priority housing system based on COVID-related needs for the short term. There's a link there. And Los Angeles, as part of Project Roomkey and Homekey, also has a plan to house 15,000 older adults be experiencing homelessness and housing instability. Just a couple of examples, all live links here if you want to get more into the depths there. Next slide. And then just highlight some of CSH's work in this space. We are building something called a Compact for Thriving Communities. It's a collective call to action to policymakers, advocates, and practitioners at that intersection of health and housing, supporting health, equity, and choice, trying to move beyond institutionalization and the challenges COVID has told us. And we use institutionalization to mean a broad term, including nursing homes, including state psychiatric or developmental disability institutions, as well as jails, as well as homeless shelters. COVID has seen the dangers of all of those settings for individuals and the need to make change. So to learn more, get involved and visit or be in touch. Next slide. And just here, a couple of examples around building an equitable response to homelessness. This is the link to the National Alliances and Center on Budget and Policy Priorities framework around building an equitable response. Housing instability, that I believe is a tool from the Urban Institute, looking at how communities target their resources for from the CARES Act that I spoke of before, to healthcare, that's the National NAACP's framework for that, and then ultimately to vaccine distribution, again from the National Academy of Sciences and Medicine, already thinking about how do we equitably distribute a vaccine. So I challenge us all to meet the moment, to use these resources on our networks and our partnerships in order to build the thriving communities we all wish to see. And with that, I will hand it over, I believe, to Bobby.
Great. Thank you so much, Marcella. So now we will turn to Bobby Watts. Bobby is the CEO of the National Healthcare for the Homeless Council, which supports the 300 Healthcare for the Homeless federally qualified health center programs and 100 medical respite programs with training, technical assistance, policy analysis, and advocacy to end homelessness. Bobby has more than 25 years of experience in administration, direct service, and implementation of homeless health services. Bobby?
Thank you very much, Melissa, and thank you, Marcella, for really setting us up. And I really want to commend Aligning for Health for putting this on. I'm looking forward to learning so much from the panelists and from our conversations. Just want to cover what I hope to cover, what I will cover in the next 13 minutes or so is just want to tell you a little bit about the council. I do want to spend most of my time talking about the relationship between structural racism and homelessness and why it's important that we address it if we're going to make progress in this important social determinant of health and producing better health and housing outcomes. And then lastly, I want to spend a little time talking about one of our initiatives that we believe is an important part of the toolkit towards a solution to addressing the health needs of people experiencing homelessness, and that is medical respite. Next slide, please. So just want to begin by telling you who the council is and beginning with our mission statement. And it is grounded in human rights and social justice. The National Healthcare for the Homeless Council mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. And a few key words there is that our human rights and social justice. We do believe that healthcare and housing are human rights, and that forms the bedrock of all that we do. We want to build a better health system, but we want to make sure it is not only high quality, but also that it is equitable. And we want to be part of the movement to end homelessness. And we carry out our work mostly through training, research, and policy analysis and advocacy. Next slide. So just want to say who the council's main community is. For the most part, it is healthcare for the homeless programs and medical respite programs. There are about 300 healthcare for the homeless programs, at least one in every state. And there are about 100 medical respite programs throughout the country. Each healthcare for the homeless program is a federally qualified health center, or FQHC, but they have funding to target and provide services in a specialized way to a special population, that is people experiencing homelessness. And the 300 Healthcare for the Homeless program served over 1 million patients without homes in 2019. They provide all of the services that any federally qualified community health center does, but in addition, have to meet other conditions, such as have to provide outreach in some way, because it's understood that people experiencing homelessness are largely outside the reach of the mainstream health center system, so we want to provide outreach to them, meet them where they are, both physically and psychologically, and each one has to provide mental health and substance use disorder services. Next slide. So I want to spend some time talking about the relationship between structural racism and homelessness, and again, why this has to be part of the solution. My mentor, Susan Nybacher, founded the organization I worked at in New York City for most of my career. She was also a founder of the council, and she has a few sayings that have stuck with me and guided me in my career. One of them is that homelessness is the result of the failure of almost all of society's system. A lot has to go wrong in the richest country on earth for us to have mass homelessness as we do. So I want to talk about, I will be focusing briefly on 3 systems. The main one is our housing system, but also touch briefly on our education system and our criminal justice system, how they are drivers of homelessness. So a super quick history of racism and homelessness. As you know, we had slavery, we had Reconstruction, we had Jim Crow, which was enforced segregation of African Americans from white Americans in all kinds of ways, housing, job opportunities, education. And that may sound like ancient history, but I'm getting old, but I'm not really that old. And I was born in a segregated hospital, in Gaston County Negro Hospital in Gastonia, North Carolina. Part of Jim Crow, and this even preceded that, was known as is racially restricted covenants. And these are part of deeds for a home, which stipulate that in order to buy that home, you agree that you will never sell that home to anyone but a non-white, and that while you own that home, no one can live there except a non-white person, with the exception of your domestic servants. It also stipulated that when you sell your house, you have to ensure that this restricted covenant is in there. So we have housing segregation that is been fomented by federal policies and local policies, as well as personal prejudice that have been underwritten and been reinforced by the real estate industry. I want to focus on federal policy just a little bit in just two areas, FHA and VA loans and redlining. Next slide. The Federal Housing Administration is the guarantor of almost all loans in the country, and that allows banks, especially if they're going to offer subsidized loans, which many loans are, but be guaranteed by the federal government. They have to get the backing of FHA, and for veterans, it has to get the backing of the Veterans Administration. So from the beginning, these two entities, especially after World War II, which was the biggest post-war boom for housing construction, the creation of suburbs, said that they would not lend to, they would only lend guarantee loans for whites. Then later, they stretched that a little, but they would only lend to African Americans for homes in predominantly Black neighborhoods. And when they were when whole suburbs were being created out of farmland in the post-war period, they were creating these communities that were designed and that were in fact segregated by race. And some communities that were integrated became segregated because if you wanted to buy a home there, you couldn't. So if you had an option, you would leave and go to a different neighborhood. So whites would move out. They would only back developments that had these restricted covenants in there. So this was federal policy, next slide, that reinforced and that created segregation in housing. So I want to point to just to the middle bullet. So this is my expansion of a saying of a ACLU attorney who gave a seminar on this in New York, here in Nashville, and that Blacks were excluded from the largest government subsidized wealth creation program in history. That's what the creation of home ownership was. And because African Americans paid taxes, and this was funded by general taxpayer dollars, they were excluded from the, unconstitutionally, from the wealth that they were helping others to create. So they were disadvantaged unfairly, and whites were advantaged unfairly. And we know how important home ownership is for creating familial wealth as an entree to the middle class, refinancing, sending your kids to college, and also for stable neighborhoods. Next slide. So I'm going to just show these slides real quickly. Just focus on the big picture, not actually all the numbers. But what this shows is the Federal Budget Authority for Housing Assistance. Marcella said that right now, only 1 out of 4 households that qualify for federal assistance to make their rent affordable so they can stay in their rental unit, and also for public housing authorities, only 1 out of 4 that qualify get that assistance, usually in the form of Section 8. Looking back at this graph, in 1979, according to this number, 2017 numbers, it would be $125 billion was the federal spending to make housing affordable for housing assistance. In 1982, it dropped to about 27 billion in those dollars. So we've had a wholesale retreat from a federal commitment to make housing affordable for poor Americans. And this is the same time, the early 80s, that we see mass homelessness explode in the country. There's a little peak 2 years for the stimulus package after the last financial meltdown, but you can see we've never come anywhere close to the 1970 commitment. And I will also add that we are still very far from that. It's about $45 billion is HUD's budget for housing assistance currently. Next slide. This shows basically the same. The red, instead of using dollars, it shows percent of GDP, but it shows how there's been a massive retreat from making housing affordable. Next slide. And at the same time, the black line is showing that housing assistance is going down. We have the tax expenditures, what it costs the federal treasury, what it costs taxpayers to forego money for homeowners by subsidizing their housing, their home mortgage interest deduction. So that has exploded at the same time that we have made housing assistance for renters, we've decreased. And we've made housing more affordable for those who really don't need the assistance in buying a home. Next slide. So moving just really quickly, education is said to be the great leveler of opportunity, making it public education, making opportunity equal for everyone. But when we think about systemic racism and how these systems interact, because of this housing segregation where poor people, renters are in one neighborhood and homeowners with federal assistance are in another, we choose to fund education through local property taxes. What that has the effect of doing is making that, and what we see is that those in wealthier communities can afford to and do spend more per student than those in poorer communities. And this is largely correlated with race. Looking at majority, meaning 75% white school districts versus majority non-white, meaning 75% or greater higher, there's a 20% difference in what is spent per student. And really, from an equitable fairness point of view, if we wanted to level opportunity, we would give more resources to those who were poorer. Next slide. The next one is just looking at criminal justice systems really quickly. The two bars on the left show that marijuana use, for instance, is roughly the same between blacks and whites, but arrest for marijuana possession is about 3.5 times greater if you are black. And that is a function of often of where you live, what neighborhoods are targeted by the police, who's subject to stop and frisk, whose car is more likely to be stopped and then have a search. Not related to usage, but based upon racist police practices, criminal justice practices. Next slide. So though many studies have shown that for most categories, the rate of criminal participation or participation in crime between blacks and whites is roughly the same. For a lot of, we see the criminal justice system exacerbates racial difference. So one of the most important things that can happen to you and your chance for your success is whether you have been imprisoned or not. And for every age group, it's roughly 5 times greater if you are an African-American male than a white male to spend time in prison. And in the crucial early years, it's almost 13 times as higher for those 18 to 19 and 20 to 24. So this is why we have much greater overrepresentation of people who are African-American among those who are experiencing homelessness. Next slide. So we know that homelessness is really bad for your health. It leads to all kinds of bad health outcomes. The most important is death. And on average, people without homes die 30 years earlier than their housed counterparts. And this is fairly consistent across the world. It's generally between 25 and 30 is the difference between those who will die on the streets versus those who have homes. Next slide. So just want to speak a minute about medical respite, and that will come up in passing later, but just want to tell you what it is. It really is for people without homes who no longer have a clinical reason to stay in a hospital, but without medical respite, this service that allows them, gives them a safe place to heal, they will go back to a shelter, back to their friend's couch, back to the streets, where they're not going to be able to heal. They end up back in the emergency room, back in the inpatient department, or back in the hospital, in poorer health with more complications at greater cost to the health system. So medical respite is a way to break that cycle. Next slide. And next slide. So it's treated for a number of short-term conditions and with much success. So just it leads to, there are links to the study, or at least the citations for these studies. We need a lot more research, but what we have show fewer hospital days per stay, reduces the cost of each day. It reduces the chances of being readmitted. 90 days, also even greater than 50% within 30 days. And it also reduces future ED visits. Next slide. So it offers a safe, legal, cost-effective discharge option. Medical respite always has case management to connect you back to primary care, but most importantly, it works best when it becomes a bridge to housing, usually permanent supportive housing, but it could be other housing as well. Next slide. So it's funded by a number of sources: hospitals, managed care organizations, Medicaid, governments, and next slide. And we're seeing increased interest in medical respite. We have a paper, there's a link recently published looking at Medicaid and managed care financing approaches. This was done in conjunction with United Healthcare. Next slide. So this is a slide that will be left with you with a number of resources on medical respite. Next, yeah. The main one I want you to look at is our top one, National Institute for Medical Respite Care. This is a special initiative of the council that was started in July, 2 months ago. And it's largely because COVID has raised the need in many communities, some for the first time, of the importance of addressing the health needs of people without homes. And we believe medical respite is a key tool to meet the health needs of people without homes. So I will stop there. Contact information is there, and welcome you to approach us if we can help you develop medical respite in your community. We've had so many people approach us that we want to be responsive. Thank you, and I look forward to the rest of learning from the rest of the panelists.
Great, thanks so much, Bobby. So now we turn to Kevin Progar, who is the Senior Program Manager at the UPMC Center for Social Impact. He works across sectors with both community stakeholders and implementation partners to develop innovative contracts that address members' needs and position UPMC Health Plan to support community priorities. Mr. Progar helped develop a Pay for Success contract that is designed to scale UPMC for You's supportive housing program called Cultivating Health for Success. And he serves as the UPMC team's lead for the Accelerating Investments for Healthy Communities initiative, which is designed to help leading health systems deepen their investments in affordable housing and advance policies and practices that foster equitable housing solutions. Kevin?
Great, Melissa, thank you so much. Appreciate being here. And also, just kind of want to call attention to the fact that I'm really grateful for the incredible work that Marcella, CSH, and Bobby and the National Council do in providing those resources that they highlighted. A lot of what you're going to see here has been built with the understanding and the leadership they have there. So just very grateful for Aligning for Health for bringing this subject to the fore, and the organizations included here that really are bringing the resources to make our approach to this easy. My real purpose here is to try to think about, how does a health system really approach these things in a way that is both beneficial to the folks we serve, the communities we operate in, and then ultimately that kind of ecosystem approach that both Marcella and Bobby had touched on. So if you're not familiar with UPMC, it's an integrated delivery finance institution, primarily focused in Western Pennsylvania, but operates statewide in a number of domains, has 4 primary divisions. One is the health services arm, which is the hospitals and phenomenal doctors that we have, including top-notch cancer care. Next is our innovations, our enterprises division, which really focuses on social venture capital and innovation. And then we also have an international division that really helps kind of take healthcare models global. And then most importantly, there's our insurance services division where I have the pleasure of working, which insures roughly 4 million people in the state of Pennsylvania right now, with almost a quarter of those folks being secured through government programs. So housing is always front of mind for us. So looking at the next slide, why does UPMC or a large organization want to take on and have something so defined as a center for social impact? And ultimately, you know, it boils down to a lot of what everybody else on the call already knows. If you're tempted to join a forum like this, you know, you're already pretty primed to the connections here. But, you know, what I really want to highlight is there is the individual motivation, which is how do we best serve our patients? Speaking to that fact that, you know, housing is not an entitlement program and only 1 of 4 people can get access to the kind of assistance that they need, then we really need to be able to step in and think about how we can contribute both in increasing the availability of units and, you know, increasing the positive impacts from a financial picture, both as a healthcare provider, but more importantly, as a citizen to our state and national governments. You know, so you see some stats that are reflected here from a great paper that some of our senior leadership put out in 2017. But ultimately, you know, we're really talking about what's often called kind of the Pac-Man dilemma, which at the federal level is Medicare and Social Security dominating spending by their growth. And at the state level, it's really about Medicaid and most states' pension contributions. So we need to step in and bring to the table our flexibility, our innovation, and our financial resources to really ensure these systems work better and make sure we're able to serve the lives that we cover and the communities we serve. So next slide. This is just, you know, quickly to contextualize how the organization's dedication to housing fits within its bigger kind of community commitment and mission. So highlighting most importantly, just kind of the phrase at the bottom here, which is our vision for housing. You know, so we invest in preventing and addressing homelessness, creating healthy and affordable housing, and those are 2 examples I'm going to dig into. And then supporting our neighbors who need help aging at home, because life-changing medicine starts with a place called home, and that notion of home and not just a place to be is a really important concept. So, you know, that's kind of where we're trying to go. So moving on. You know, here's really how we start thinking about the range of housing options that are out there and what it means. So, you know, home is, you know, a pretty defined thing for most people's mind. Bobby touched on the FHA and its, you know, kind of historical legacy and kind of what that means. So, you know, how do we get folks, you know, from an emergency situation all the way into kind of that most stable environment? So you can look at these different bands. You know, we're looking from top to bottom at homelessness and housing insecurity, you know, focusing on emergency needs, medical respite, transitional housing, and supportive housing, which are all places where health systems generally see a strong connection. Then the affordable housing band, you know, is really focused on public housing, affordable rentals, and affordable home ownership. And that top band, where we're trying to get folks to ultimately, is affordable rentals and home ownership. Just because that is how we start correcting some of these inequities long term and thinking about how to balance, you know, our communities. So you can think of this slide in a couple of different ways. You know, on the right are kind of some of the folks and populations who we serve as healthcare providers and a healthcare insurer, and where they kind of fall into the spectrum. But then you can also kind of look at this as, you know, something of, you know, Maslow's hierarchy, in that, you know, there's a lot that needs to be done to address people in urgent situations, which speaks to emergency shelter, medical respite, and a lot of those items. And then, you know, ultimately, how do we move people kind of up this pyramid and up the ladder is the ultimate goal. So next slide. Digging in a little bit, Cultivating Health for Success is a program UPMC Health Plans operated with a community partner called Community Human Services for over a decade now. Historically, the first 10 years of the program relied on HUD homeless individuals receiving continuum of care dollars, and that managed to serve 60 people, over 60 participants over the life of the program, with 16 people still currently enrolled today. You can see on the slide, a lot had pretty significant comorbidities along with behavioral health and drug and alcohol use as major factors. Ultimately, over that 10-year period, we saw that we weren't only recognizing savings through the program, but also really finding people the right way to care. So unplanned care went down, primary specialty visits went up, pharmacy adherence went up, and we still net out at over $6,000 a year per member. So we're looking at that success. We said, what would it take to expand this program to more populations, and started working with CSH and NFF to really drill down and think about what sustaining a model like this would look like. And we were able to expand the criteria for members that are experiencing any level of housing instability, try to get those folks connected to voucher programs through our local housing providers. And so far, we've really been able to see some early successes through housing 44 members, and also, taking a moment to really dig in and think about how to make this sustainable over the long term, which includes adding bonus payments for the housing related outcomes of the individuals through the program. And then also, continuing to kind of increase our evaluation rigor. So, we'll hopefully be able to share more in the years to come. But so far, we're seeing an even bigger improvement from both a utilization and a cost perspective for these members that are housed here. So next slide. But even with that success, and we have similar successes with our nursing home transition programs for seniors, the reality is the #1 barrier for people getting into housing are criminal background records, and the fact that there just is not enough assistance or enough supply in the marketplace. So Accelerating Investments is a program that was funded through the Robert Wood Johnson Foundation. It's really focused on expanding market access and kind of focusing on that market level impact for affordable housing in particular. We've been working with a pretty interesting team of cross-sector partners, including the largest nonprofit housing developer here in the city of Pittsburgh, some local community development finance institutions, the mayor's office, a few other developers, and some really great community collaborative organizations who offer a lot of technical support to different nonprofit partners. And so we're right on the edge of kind of being able to talk more, but we're exploring actively what does it mean to use our balance sheet resources to really increase the units available. Because when we look at the need in Pittsburgh, it's somewhere around 20,000 folks who make less than 50% of the area median income are not able to find a unit. So we're hoping that we can kind of tackle that, and we have a plan that we think will produce somewhere around the neighborhood of 1,000 units over the next 5 years. So excited to talk more about that coming up. Next slide. And then ultimately, this is kind of where I want to try to pull the thread through is, what are we trying to accomplish, and what are the tools that are available to do that? So oversimplifying things is sometimes a really helpful exercise. So when we think about the activities we're taking on as a payer and as a health system, it's really, how does this benefit our member? How does this benefit the neighborhoods where we serve? And how does this really make strategic long-term system changes? Focusing on that ecosystem is really that kind of top box. And then what are really the financial levers? Because that's what things boil down to. We want to work as much as we can with existing public resources and public dollars, and bring in our own resources and technical assistance to make sure that we're designing programs that work. So, there's charity, there's partnering through any kind of level of agreement and contracts, and then there's investing, which is kind of a whole higher level piece, and really using the balance sheet. So Bobby touched on medical respite. So that's one place where we've offered annual contract for a certain number of medical beds with our medical respite provider, Bethlehem Haven, which has been seeing tremendous success. So that's kind of a example of where charity can really benefit members. Looking at a place where partnering can improve neighborhoods. The Erie Community Census is a partnership we took on with the Hospital Foundation, a local FQHC, and a regional employer in the city of Erie. We split the cost of hiring a community team to go out and really see what the needs of the community are through a door-to-door survey and an online component to really start with a ground-up community plan. So that work is kind of ongoing, but has resulted in the creation of a community health and wellness center, education center that utilize new market tax credits in one of the most diverse neighborhoods in the city of Erie, which is very exciting stuff. And then kind of looking at an example of, kind of where investment and systematic approaches come together is through our Accelerating Investments for Healthy Communities work. We've managed to start a Pittsburgh Preservation Working Group, which is really focused on ensuring that we keep any subsidies in the marketplace intact through working collaboratively across sectors with both developers and government officials to understand which properties who currently provide affordable housing might convert to market or might run into structural issues that would decrease the health of the residents there. And we're trying to come up with both a proactive approach to understanding the market need and establishing how we can provide financial resources at the same time. So that's been an interesting conversation and outgrowth of the work that we've done to date. So ultimately, that's it's a matter of really trying to fill up these boxes in more ways and more than just in the housing domain. So that's the place we're kind of going to leave it, and I look forward to discussing more kind of the way we can enable more of this work. So thank you all.
Thanks so much, Kevin. Okay, and for our final speaker, I'm excited to bring you to Callie Seltzer. She is the National Director of Housing at LISC, where she is responsible for developing and executing affordable housing production and preservation strategies across 35 urban field sites and rural networks. Callahan oversees numerous programs in areas of research aimed at surfacing innovative approaches to housing, health and wealth building, and works to advance these models with peer learning, technical assistance, and capacity building. Callie first joined LISC in 2007, where she has held a number of real estate finance roles and returned to LISC in 2018. Callie?
Thank you so much. You guys can hear me? Excellent. Thank you everyone for being here. My name's Callie, and I'm based in DC. I work across our field. For those of you, in the next slide, for those of you not familiar with LISC, we've actually made investments in every state in the country, but we have a network of about 37, I say about because we're always sort of expanding or shrinking geography, 37 field offices and a large, amazing rural network across the country. And we are really committed to comprehensive community development approach. So that includes investments in housing, investments in financial opportunity, including various community-based centers for financial opportunity, healthcare or health clinics, federally qualified health centers, a number of investments around childcare and educational facilities. It's really a range of place-based investments. We can move next slide, please. So I would just say, we've been doing this for 40 years, and in that time, all of our work and really community development, I think, has been about what happens outside of the clinical setting. We don't say that, but that is the work of community development that my colleagues here today are talking about. Your job, your access to transit, mobility, economic mobility over time, how readily available is healthy food to you, all of these things. So we really look at this from a housing perspective, sort of in four ways. So we do capital investments. We're working with partners to kind of breathe new life into under-resourced communities. How do we get healthier, safer housing, preserve existing subsidies? Kevin referred to that. That's sort of a big part of our work as well, preservation work, to make sure that those properties are protected and preserved as affordable. The second bucket is sort of planning and advisory services, and that's really drawing upon our sort of very authentic community relationships, because we have this network and on the ground presence in so many places. We're well positioned to facilitate kind of a diverse set of stakeholders. And so whether that's being involved in community health needs assessments, health impact assessments, neighborhood planning. I'm a planner by training. That's sort of just a lot of how our work is shaped. That early kind of tip of the spear, being really trying to be forensic and figure out what is actually not working in a community. You know, what's missing from the capital ecosystem, and that can inform our investments better. And then third, you know, programs and services that really complement and sustain investments. So LISC and healthcare organizations we work with healthcare organizations to design and implement large-scale initiatives, and then also very customized interventions that try to solve for very specific challenges. So whether it's a weird policy problem around vouchers, figuring out how to make vouchers or limited voucher authority go further, how to help you know, hospital system actually serve their employees or create new housing opportunities for their teammates. And I think generally, you know, we're really well positioned to track program progress and assess outcomes in terms of health and health determinants. So the fourth is just our very active presence on Capitol Hill and working at that, you know, local and also state level to really rally support for government programs that make our efforts possible to, you know, these revitalization efforts, and public policies and resources are really indispensable in helping lift people out of poverty. So that's kind of an overview of our strategies and how we do this work. Next slide, please. I don't think this will be new to any of you, but you know, when we think about housing and social determinants of health, there's really no place in the country where you can live on minimum wage and afford a 2-bedroom minimum rent. There's some really disturbing data coming out about, of course, the backlog of rent and, you know, sort of this moment of reckoning. I believe Marcella in the beginning said, you know, a moment of reckoning about where we actually are, you know, what happens outside of the clinical setting, being so critical to health. And then I think the deeper issue of how do we even quantify, you know, sort of the psychological stress really that our communities are under right now, a tremendous amount of trauma, just from fear of eviction or displacement, compounding on many other vulnerabilities. Next slide, please. This is just a slide I think is helpful in sort of tracking those housing challenges through to the health impact. So just thinking about the social determinants of health continuum of development, I don't think this will be surprising to any of you either, but you know, looking at some of what Bobby discussed, you know, residential segregation and very discriminatory by design housing policy and practice, and this much longer history of disinvestment, and we are feeling the pain of that in so many ways in housing. We've also seen sort of a divestment of federal support, and we've really relied heavily for 40 years on private investment into the affordable housing arena, which can be amazing in terms of the low-income housing tax credit being the vehicle for affordable housing investments. But it still is not getting at the demand. And frankly, the demand is increasing in every city that LISC works in. 1 in 4 served, as a few of us have relayed on the call. I think that metric has shifted. We also used to say that if you were paying more than 30% of your income toward housing, you were considered housing burdened, and that metric has shifted in 10 years. You know, it's more like 50% if you're paying more than 50%, because there's, I want to say, close to 10 million Americans in that bucket in the U.S. And so we've had to shift the entire metric, which you know, speaks to a need and a demand that is far outpacing the supply and what we're able to build. And a lot of that, we can move to the next slide. A lot of that's really directly related to the need at sort of the the hardest to serve income bands. So thinking about people experiencing homelessness, people all the way up to 30 or 40% of area median income, 50% of area median income. The tax credit program is really, really good at serving people at 60% of area median income and above. Below that, a lot more subsidy is needed. And I think the question for all of us in our communities is, where are we going to get it? Subsidy cannot look like debt. It cannot look like equity. It really is, it's really, grant commitments and or federal support or state or local support via vouchers. You need that subsidy in order to reach those households. So just thinking here about housing stability and affordability, you guys, I think, know this story, but falling behind on the rent and various other forms of instability over time, and health quality, of course, substandard housing conditions being a compounding issue for many of our communities, including issues around lead and sort of systems level problems that individual place-based housing investments cannot solve. And then also thinking about housing as a platform, permanent supportive or enriched housing with services really can reduce that cost of healthcare and public services. A couple of examples sort of embedded here in our work in various geographies, LA and Arizona. You can move forward to the next slide, please. Thank you. So as I mentioned earlier, we are focused on locally driven solutions. So I think the evolution for us in understanding our work as a CDFI and as a capacity builder and a technical assistance provider, our work in the context of health and this moment of reckoning, racial inequity and gender inequities are driving social determinants of health in ways that we have not seen before, and never in such real time have we had data showing this. It's made us as an organization, I think, much more intentional in how we talk about our work, more strategic, hopefully, about who's involved and who's advising us. And as an intermediary, much of our role is to be both sort of the organizers on the ground in our local offices, and we've got program officers every night of the week attending resident or tenant meetings, community planning charrettes. That's part of the work. And then understanding those community needs at a very granular level. They understand why certain projects also aren't happening. What's missing? What's the policy nudge or the missing piece of capital, or the sort of local state of play that's keeping us from getting more production or preservation. And then communicating as an intermediary, communicating those needs back up to the institutions that want to address them. So we're trying to be very intentional about seeking investments from healthcare that actually try to expand outside of what's been our bread and butter, which is the Community Reinvestment Act, the CRA type investments that banks make, and in large money center institutions. And so healthcare has been a really great new set of partners for us, because we are, framing housing as a basic human need. I think we understand and speak each other's language to some extent. But in terms of how that plays out in physical redevelopment or physical preservation, production strategies, it's a mix. Here you can see, mixed use development, a variety of permanent supportive or enriched housing, service enriched housing, a lot of preservation work, and a lot of programming around healthy housing, home repair, and how do we support developers of color to do this work in their neighborhoods. So these are place-based investments. They almost always require grant or subsidy dollars if we really want to get at that lower income band and households that are pretty squarely left out of systems. And that's the hardest part of our work in terms of housing is finding and solving for that subsidy. We've found that healthcare partners can really be creative in thinking with us about how to do that. Next slide, please. I mentioned home repair. It's a pretty widely used tool in terms of immediate health impacts. But this is just an example of the Home Preservation Initiative in Philadelphia, and really looking at asthma outcomes for 5 neighborhoods in West Philadelphia. And what can we do in terms of combining home repairs and health worker home visits? So you have that kind of leave behind and that touch point to be tracking, you know, what lives are looking like on the other side of the investment. Next slide, please. This is a really great project here in DC, the Conway Center. I don't know if any of you have had a chance to visit, but if you ever get to DC when things return and you would like to see it, please let us know. We really love to show this project because, one, I live here, but also because it's just a really excellent example of public-private partnerships, and also this like using every tool in the tool belt to create a really beautiful, really powerful example of community development with a lot of different partners, private and public, and years of planning involved. So this is including the New Markets tax credit allocation for a federally qualified health center, of course, construction loans, which is a large part of what LISC does, you know, kind of early stage financing, riskier level or stage financing, if you will, that your typical banks won't take on, and then also using our affiliate, the National Equity Fund, to bring in that tax credit equity, which really serves as a grant. And you can see kind of some of the outcomes here on the right in terms of the number of units, new patients served, really connecting people to childcare, also connecting people to a pharmacy, and sort of all those interrelated daily needs. Go to the next slide, please. Housing preservation, Kevin was talking a little bit about this, but it's really core to our work, and thinking about how we preserve existing housing opportunities, and really also how do we double down on connecting people living in those properties to a stronger network of kind of evolving healthcare partnerships and community development. This is an example in Minnesota. It's in Minneapolis, and it's 300 units. It takes a lot to preserve 300 units of housing. Might actually shock some of you how much work and brain damage goes into this, but a really amazing outcome in terms of people that are, you know, it's an anti-displacement at a minimum, and actually, you know, we're looking at 300 units that are preserved for 30 years at least. So that's a really exciting outcome, and something that, frankly, you know, federal government cannot do alone, and private partners cannot do alone either. So this is a good example of our preservation work. Next slide, please. I'll just talk a little bit about housing and economic opportunity. As I mentioned, we are pretty focused on community development comprehensively. So we run what's called the Financial Opportunity Centers. They're actually run usually by our partner organizations that are preparing kind of the workforce of tomorrow for living wage jobs, financial stability, building career support with financial coaching, income supports that maximize success, and doing all of this more closely these days with healthcare partners, and actually trying to do place-based investments of financial opportunity centers in catchment areas for specific healthcare partners. We can move to the next slide. Actually, we can probably just keep moving. I want to be conscious of time, give us plenty of time to talk. So that is, I think, just a few examples, you know, of how we are working together to figure out, you know, how the systems for coordinating, delivering, and financing, and also paying for services on the back end. How are we doing this more creatively? You know, housing and regulated housing in particular is deeply constrained set of housing assets or resources. We are very, very adept at getting, I'd say, creative in trying to finance new housing when you're in a constrained environment. So how do we actually attract investors that are interested in health outcomes and housing funds to projects? Do we do that at the fund level? Do we do that at the project level? Or are we trying to be kind of the connective tissue in terms of services across these assets? So I think we're, as an intermediary, doing a little bit of all these things. We're often sort of more locally, driven based on needs that exist on the ground versus sort of a top-down approach, which I think is really powerful. It means that the developers, the projects that we work with, they don't also always have to bear the burden because we can raise capital nationally and through these larger partnerships. So there's a lot of financial innovations that I didn't get into talking about today, but for the sake of time, I look forward to talking to you guys a little more in the breakout. And if you're interested in learning any more about how we do this in a place-based way, please feel free to reach out. Thank you.
Thanks so much, Callie. And thank you to all of our panelists who provided a lot of food for thought for our breakout discussions. So we're going to move now into some breakout rooms for all of the participants to be able to have more smaller group discussions. Given time, we'll probably only give each room or in total about 8 minutes for each of the groups to discuss. We have pre-assigned each of you to a room, and we have pre-assigned a question for each of the rooms to focus on. The first few groups will focus specifically on this first question about key barriers in either implementing, designing, or scaling and trying to make sustainable some of these types of interventions that many of the panelists spoke about. The second question, which will be groups 5 through 7, which will focus on, what can Congress or the federal government do to help in addressing some of these challenges or help make it easier to take advantage of some of these opportunities and innovations that the panelists mentioned. And then finally, the last groups will focus on what is the future of health and housing. Each of the panelists talked a little bit about, where they see some of this going and some of the innovations that are out there, but, would love to kind of hear from each of the participants as well from your perspective. So with that said, we'll give each group about 8 minutes, and we'll transition you now in, and we'll give you a reminder with about 1 minute left about when we'll come back to the group discussion. And then we'll talk with each of the panelists in the larger group for the remainder of the time. Anyways, so I know that there is a lot to discuss. There were a lot of themes and questions that were raised by the panelists as part of their discussions. And in an hour-and-a-half conversation, we are not going to be able to even discuss all of them, let alone come up with a set of here's how to fix and boil the ocean. But would love to maybe hear from some of the panelists in the very short time that you had in the breakout rooms. And again, apologies for the technical difficulties there, but what are some of the key themes that you think about when you are thinking about some of these questions about either challenges in scaling or making various interventions sustainable? And then we'll move on to some of the other questions.
This is Kevin. I can do this kind of quickly. Just first time went really fast there, but heard kind of quickly that the proof is out there as far as from a research perspective. We know these programs work, but they typically only work with 12 people. So what does it take to get to more like 1,000 people served through any of these individual programs? And that's kind of where we got to. And the one idea that got floated was just kind of this: how do we come up with tiers for homelessness or housing insecurity that could be reimbursable, or bring other kind of organized funding in a broader way.
Mm-hmm. I'll speak a little to sort of the development and finance side. We talked a little bit about key barriers being, on the policy side, certainly at the local level, zoning and NIMBYism, just difficulty building housing generally, let alone housing that serves or supports people at lower income bands. It's really tough in every community, and we don't have many tools to finance it to begin with. But on top of that, you have social constraints or sort of these other barriers, non-monetary. And we also talked about that disconnect, for Medicaid, that you can't actually fund housing. You have to have a workaround to get the dollars that are very much needed. And that means you have to have a really strong developer and partner, and that partner has to really be in it for the long run, I think is key. That's not typical in real estate in this country. You're really looking to these operators that want to own, operate, or provide services sort of in perpetuity, or else you're leaving people in the lurch, and you probably can't get your financing to begin with. So I think we're talking about a whole different set of real estate assets, if you will.
So how do you begin to, in thinking about like building partnerships, how do you begin to address some of those questions, whether through various financing models or, the types of entities that you're working with, or even, is this something that needs to get addressed at a systemic level, rather than, thinking about the one-off kind of relationships or contracting that you might put in place? This can be for anyone.
I can speak to just
non-panelists. Feel free to chime up. Everybody has the power to unmute themselves. Just a quick reminder, we have an open forum. Sorry, guys. Go ahead.
I was gonna say, I look at it as solving for that longer term operating cost first. At least when you're talking about developing, building, housing, if you don't have those longer term dollars, then you don't have a program, or you don't have a stable, project. We can all get construction loans. There's plenty of CDFIs that do shorter term financing acquisition. It's those longer term operating dollars that are so difficult to come by. It's the reason we can't get more even out of our LIHTC program. So I kind of start there, and that actually determines, from a systemic standpoint, we need more investments at the federal level, I think, in those long-term operating dollars. But that informs what you're able to build.
Yeah. And Kevin, I'm curious,
Yeah.
I know that UPMC has dabbled in kind of social impact partnership and bond type of approaches to get a little bit at the financing question and pulling together different public-private partnerships. What has your experience been on this?
Yeah, so it's twofold. So, speaking to what Callie had mentioned around the long-term financing, that's one place where, just so everybody knows, affordable housing developments default at less than 1% if that piece is there. So that's where that comes in. And so we've been approaching these programs for using government subsidies, either HUD direct vouchers for homeless individuals or local public housing resources for other folks with some other level of housing insecurity. But there are real ways to think about the next step in building contracts in with providers, whether that's somebody who does housing work directly or a developer themselves, to think about, we're able to kind of think about our member in this context, but that can really lead to these other long-term financing pieces as well. So we continue to think about it, but the challenge again always comes back to what are we really paying for and what are we allowed to pay for? Because the willingness is there, but how do we make those kind of investments in a way that have those upstream system impacts?
Mm-hmm.
Yeah, Kevin Marcella, totally agree with what you're saying there. Part of it is, I think you have to take the time, and during COVID, it's been so difficult to take the time to build those long-term partnerships, determine what your joint priorities were, understand enough about the other system in order to understand where those pain points are. So I think we're pretty good at this point at understanding a number of those classic pain points, i.e., healthcare can pay for Kevin's, health plan or any other health plan can pay for its members for services as long as they remain members. Callie's got developers that are trying to build housing that needs a 30-year commitment in regard to services. Wow, that's a disconnect there. So outlining a lot of those structural disconnects and then trying to find a way. When I was with Philadelphia, we were able to shift a lot of our services funding that was coming into housing onto our local managed care organization because our homeless system was paying for drug and alcohol counseling. It was paying for case management. And we were able to partner with the local health plan and say, okay, for your members, can you pay for that? That's what you do. Let's shift some of that money, and then let's take that money that we've been able to shift and use it to build more units, use it to have more operating subsidies, like Callie was talking about, because that's the biggest challenges there, et cetera. So there are strategies, but you need those long-term relationships, and you need to understand just enough about the other person's system to know, when they're truly being honest about yep, I can't do this. Kevin's health plan, if a person's not a member of Kevin's health plan can't pay for any services. And understand enough about those other systems to know where their structural barriers are, and then have a partnership that really works creatively to get beyond them.
Mm-hmm.
I would just like to add on what Marcella said, two things. One, so it's important to have broad coalitions and partnerships, and it's best to the extent that government can be there, because that can help to solve the wrong pocket syndrome of who's going to pay for this. Really figure out who really benefits the most from it, and sometimes it's an insurer, sometimes it is a developer, but often it is society that really gains the most by reducing homelessness and helping to meet the health needs, especially when we're talking about Medicaid paying for a lot of this. So we need to really try to bring a fuller there. And the second part, and not to sound Pollyannish, but I really also what Marcella said in her presentation about moving from a model of scarcity. All that we're doing is really working around the edges because we have to, and we have to keep doing it. But as Callie said, if we had more federal investment, even back to 1970 levels to where we are today, we would not have this problem. So we should continue to press for systemic solutions while we are working on immediate needs, meeting people's immediate needs now.
Mm-hmm. So I guess noting that we are a little bit at time, I guess would love to hear from all the panelists just very quickly, you know, if you had a crystal ball of where you see the future of some of this work going over the next year to 5 years, you know, what would be your, you know, top tier goal for where this kind of intersection in health and housing moves forward over the next year to 5 years?
So as UPMC's housing translator, I think the real issue and often the federal framework is the timelines are different.
Mm-hmm.
Health systems think about quarters and years. Housers think about years and decades. So we need to come up with some kind of way to reconcile those things and come up with something that works for both groups. We often try to play in each other's sandboxes. We kind of need to think about something a little bit more systemic in how we talk to each other.
Great point.
I think there's an understanding that these sectors are different enough and overwhelmed enough commonly that there needs to be some specific support around that intersection. It's not enough to say housing, you need to come to the table, or healthcare, you need to come to the table. It's important to have that support in the middle that brings them together. There's just not the time, the energy, and really the understanding in each sector enough. I mean, you're going to get, you know, amazing plans and situations like, and projects like Kevin described, et cetera, but that's for the A++ students. We need something that's able to be scalable, et cetera, and more folks can really sign on.
Anybody else? All right. Well, with that, I just wanted to say thank you, especially to all of our panelists for taking the time to, you know, talk about your work today and to share with everybody. I see that there has been some great comments in the chat as well. And thank you everybody for joining today. Please let us know if you have any questions. We are happy to you know, answer any questions about Aligning for Health or connect you to any of our panelists. We really appreciate your time and have a great one.
Thanks.
Thank you, everyone.
Thank you.